This conference will now be recorded.
Good afternoon and good morning, everyone. Welcome back to the ACRM pandemic web series, where we are trying to get good information around what's going on with telemedicine in the field of rehab. We've covered some folks from industry, APTA, ASHA, and today we have guests from the American Occupational Therapy Association, Monica Wright and Tammy Richmond. Just a little bit of background about our guests. Tammy is an OT and exercise physiologist with an extensive clinical background in rehab, wellness management, and technology. She is the CEO and founder of Go to Care, an online telehealth company that provides education, consultation services, and technology solutions. Tammy serves as an advisor for 5+ Therapy Inc. and Personal RN. She previously served as the chair for the Telerehab SIG at the American Telemed Association and is the content expert of the AMA Telehealth Coding Work Group for the American Occupational Therapy Association and has also co-authored the AOTA Telehealth position paper. We are also joined by Monica Wright, who has over 20 years of experience in coding, billing, and practice management. She has 3 certifications from AAPC and has taught coding and billing to students, physicians, and staff of private medical practices and within hospital settings. She is currently pursuing a master's in health administration from LSUS, and she is the manager, coding, and payment policy advisor at the AOTA. So welcome, Tammy and Monica. You're both there, yes? Hello?
I'm here, thank you.
Oh, great, great. Okay. And I'm just sharing my screen. Excellent. So we will get started. Just a reminder to everybody, please mute your phones. And then also, if you will post any comments that you have in the chat, and we will be getting to those during the Q&A period. So Tammy and Monica, welcome. I'm going to go ahead and move right into the slides. We've gone through those, our disclosures. So if you want to kick it off with our learning objectives.
Sure, great. Thank you, and thank you for the opportunity to speak with the members of ACRM today about telehealth and occupational therapy. This is Tammy. I will be starting first, and then Monica will join us as we move into more information about coding and billing for telehealth services and occupational therapy. First of all, we want to extend our hope and prayers that all of you and your families are staying healthy. The good news is that AOTA already has dedicated telehealth informational and resource pages available at their web portal at aota.org. Or we invite you to Google AOTA Telehealth and/or AOTA OT COVID-19. That will instantly take you to the dedicated pages that will support today's presentation and will provide all of you with a place to go back to stay updated and informed if you want to learn more about billing, coding, and other informational services. I do want to just start with today's learning objectives. We're going to provide an overview of telehealth and occupational therapy. And this is based on the numerous emails and social blogs that I've been looking at and peeking into as I realize that providing services through technology is sometimes new for many occupational therapists, and therefore some of the lingo that you may be reading about in social media, in bulletins sent out by payers and policies, rules, and regulations may seem a little foreign to you. So I first want to just go over some basic telehealth definitions and some concepts of services that we already have evidence-based utilization in. And then we'll be discussing COVID-19 telehealth coverage for OT that has suddenly provided the opportunity for OTs to provide telehealth services through these technologies. And then we'll also review the COVID-19 AOTA resources for OTs and folks providing OT services. Okay, John, next slide. So just to start off with the basics, you're going to hear the word telehealth and telemedicine used interchangeably. They do mean the same thing, so I don't want people to be fooled by the word medicine versus health. Originally in its pioneering days, telemedicine was a model that was mainly physician-led. So therefore, the word telemedicine made sense. But over time, the word that has been adapted and adopted and used in rules and regulations and by payers is the word telehealth. It also includes healthcare services, health information, and education. And that's important for us to understand this broader sense of the use of telehealth conduits or technologies. So in the AOTA telehealth position paper, it is the application of evaluative, consultative, preventative, and therapeutic services. And these services are being delivered through various types of hardware and software, or what we consider to be telecommunication information technologies. Next slide. Also important to note, which can get confusing, is these larger and bigger words: synchronous, asynchronous, what is the originating site and the distance site. And I'll also just touch on here on this slide about licensure portability. So synchronous is the word given to the format, the way that we are connecting to our patient. Synchronous means live, interactive, face-to-face communications, or kind of in today's slang, just video conferencing. So I see you, you see me, we're online together, and between us is the software, be it GoToMeeting, Zoom, or something else. Asynchronous is a store and forward type of information format. It captures video, images, chat, instant messaging, or emails. So I'm not viewing you. You and I aren't seeing each other, but we may be exchanging information by typing, or I may be reviewing a video that you captured for me, and I may want to get back to you with some information to advance your plan of care. This becomes important in today's conversation because Monica is going to be talking to you about Medicare e-visits and virtual check-ins. And this is when understanding the difference between synchronous and asynchronous is important. Asynchronous may also include things like a telephone conversation. So keep that word in mind as we move forward through today's presentation. The originating site. So this is where the care is taking place. It's not the provider where the provider is sitting. It's actually where the client is located and or where the store and forward data is originating. This is important for purposes of liability, right? So where the care is taking place is where we're liable for. And almost all states have written laws and regulations around telehealth. So again, the originating site is where that client is located. The distance site is where you, the provider, is located. And as we move forward through today's presentation, you may hear about the originating site or distance site being waived, that it may not matter to certain payers or the federal government where the client is located because some people are being displaced at the minute. So therefore, you may be providing care in a person's home versus at a clinic versus at a regional center or a short-term nursing facility. So keep in mind, before COVID-19, the original site was always meant to be where the client is located and where their home address is located. Another interesting thing to keep in mind is where your licensure should be at. So you must be licensed prior to COVID-19, you must be licensed in the state where the patient's located because that's where the care is taking place. You're liable for the care there. You're going to hear about today that some of the payers may be waiving this licensure requirement. And in fact, that's what AOTA has also been working on is licensure portability compact, where if you were entered into a compact, we could provide care across many states all at the same time. So again, licensure portability here may or may not be waived, but at the present time, you should check with your state regulatory languages and your state government as it puts out public bulletins about COVID to see whether or not you need to be licensed in the state where the client is sitting or the child or family that you're providing care with. Next slide. A couple of other terms I'm going to go over with you today is slightly on the more boring side, but I do want you to understand when you read these what they mean, because you're going to talk about payers and policies providing these words in something that you're reading, and it may not completely make sense to you. So there are things like the HIPAA privacy statement. That's a document that I give my patients, or you should be giving your patients prior to them receiving any type of service, in person or online, right? That privacy HIPAA statement. HIPAA compliant platform versus software versus another word you may see is portal. So I want you to understand that software is now a way that we use to see patients. We are on a GoToMeeting today, which is an application, an app. It is a software, and the manufacturing of GoToMeeting may or may not be HIPAA compliant. So it allows us to talk to each other, to see each other, right? So it's a software app. You log in like an app, and you may have to download something. That allows us to have all the necessary privacy and security safeguards. So you may be asked to see whether or not the software you are using is HIPAA compliant. Then there's HIPAA compliant platform. So a platform is the whole caboodle. It's a whole system of networks. And I try to explain the platform in this analogy. It's like a mall. So when you go to a shopping mall, you have the whole huge complex, but in the shopping mall, all these various stores, and all those stores do something differently or somewhat similar. So a platform is a word given to a network system. And on the system may set several different types of applications. They may allow you to view allow you to chat through portals, which is a way a patient logs in and talks to a provider in a secure way. It may also have different applications, so you can do self-assessments, check whether or not you're following a healthy lifestyle. So a platform is all conducive, and it's usually fully integrated. So it allows different providers, multiple dashboards, different types of portals, allows technicians to be on board, and it's all under a platform. The third word that often comes up, I read about in blogging and all the public bulletins going on in paying and coding, is the word portal. A portal is a type of application that allows you to communicate with your patients. The patients are normally required to have a login. So when they log in, they're in a space on the application that's only shared between you and them. It's very private. So an example of this is you may have gone in for a wellness check, and during that wellness check, you had some blood work taken, and afterwards the doctor says, well, if there's anything that I need to mention to you about the wellness visit, check into your portal and I will send you a message there. So it's a way to communicate to a provider where I'm not seeing them online, but we're communicating inside of a framework that is private and secure. So as we move forward, not only with today's information, but as telehealth bulletins get put out, look for these words, check for COVID-19 waivers on software and platform and portals. Okay, next slide, please. Inside the telehealth position paper at AOTA, we recognized that there was evidence to support these 5 service models in occupational therapy. They are evaluation, consultation, intervention, monitoring, and supervision. Most time when people think about services through telehealth technologies, think of evaluation and the regular intervention, right? So taking what you do in person and moving that to an online moment where I'm seeing a patient in their home and providing services. But we also have other moments where we're actually able to provide effective and efficient services in the areas of consultation, which you will hear about today when Monica talks about the e-visit under Medicare, which is really a consultative model of service. It's a check-in. It's you being able to chat with your patient to perhaps clarify or progress something in their plan of care that wouldn't be a full-out intervention. And then under areas of monitoring, which you may hear about often in remote patient monitoring. This is something that we typically don't see OTs doing. However, if you're working in a wellness model, you may have this monitoring piece. Or in an area where I work in employee health and wellness and injury prevention, we may be monitoring an employee's complaint of a soft tissue complaint while they're at work. And we may not be having a full-on intervention, but we may have what we call a check-in, monitoring their progress as they go through their work during the day. And then supervision is often used for supervising students. Next slide, please. Regardless of COVID-19, regardless of where you're at, it's important to understand that there are still required telehealth documents. I would advise you to please check with your state board first to see if there is any telehealth documents that are required on your scope of practice. But most commonly, you'll see I have these asterisks, most commonly in every state, when you're providing telehealth services, you will need a telehealth informed consent, which is your consent to treat. Now, it looks like and sounds like a regular informed consent, except there's some added paragraphs about the idea, the actual fact that you're going to be seeing people online and that there is this connectivity between you that may or may not be interrupted, right? And there also may be the moments where you have to bring in a technology or technical customer service to check on the technology if it isn't working. So again, there's a couple of added paragraphs around the informed consent. In certain states, you can go ahead and just get a verbal consent and sign off on it yourself in a written moment on your side and put in the medical chart, and or certain states require a written informed consent before you start. So again, check in with your state board language and or your state rules or regulations around telehealth. The second important thing is your competency checklist. Providing care online is no different than providing care in person. There are ethical and legal guidelines that must continue to exist. And one of these is we should be able to demonstrate our competency in the areas of telehealth. So therefore, it may be that your state board or the state that you live in their legal and regulatory language at the state level, asks for this competency checklist. Sometimes actually payers will ask for it. So keep in mind, if you don't have one, or if you do already have an existing competency checklist, you may want to add into a few features that involve the use of technology. The other icons on this page are just a reminder that we still have to write a daily progress note. I do recommend that you, somewhere on that progress note, dictate that you were providing the services online for the sake of professional liability, and that you may be asked somewhere down the line to provide a patient satisfaction survey to know how the telehealth session was going. And then just to get started, it may be important that you put together a participation screening. Telehealth is not for every patient and their family, and it's not also for every provider. There are just certain types of services that we need to do and should do in person. During this COVID-19, it becomes a challenging time because there may be moments when we really need to see this person, and the entire relationship may be online. So you may want to ask certain questions ahead of time, right? What kind of technology do you have in the home? What is your normal bandwidth? So that's what we mean by participation screening. Next paragraph, next slide. At this point, I'm going to pass the presentation off to Monica.
Thanks, Tammy. So with everything that Tammy has just said, we also need to be aware that COVID-19 has impacted telehealth tremendously. And one of the things that it's impacted is a lot of the insurance companies are now changing and waiving not only who can provide these services, but some of the requirements for the services as well. So when you're looking at what the insurance companies are requiring and allowing you to do, it's very important that you're looking for all of these things. A lot of these things Tammy just discussed. The types of service they're now allowing, the health sites, do they still require that originating site, or is it now okay for the patient to be in their home? Are they allowing synchronous telehealth, or are they just asynchronous types of services? Is it just for established patients, or can you also do this for new patients now? What are the copay requirements? Is HIPAA being waived, or do you still have to have a HIPAA compliant platform? And that licensure portability, do you have to be licensed in both the state that you are in and the state the patient is in, or has that been waived at this point in time? So these are things just to be aware of. This is all really important. We're going to go over some of the private insurance policies and kind of you'll see how some of these things come into play. But these are things that you need to keep in mind as you're looking at these new telehealth services. Next slide. So one of the first things that you must be aware of to determine whether or not you can perform telehealth is whether or not it's within your state scope of practice. The state scope of practice governs what you can do as a practitioner, and it's very important to be aware of what each state requires, especially in a telehealth situation where you might have more than one state involved. AOTA has a state-by-state chart of the occupational therapy statutes and regulations. Next slide. And at the end of the presentation, we have a link that shows you where you can go and get this information. So, but it's right there for you to be able to look up very easily and see what are the statutes and regulations for your state, what is required, and what does your scope of practice say in regards to telehealth. Next slide. So once you're established on what the state allows you to do, then we start looking at billing requirements. And keep in mind that these billing requirements vary from payer to payer. There is not a set telehealth guideline, unfortunately. We have to look at every payer individually to see what they are requiring. When actually billing for the services, there are a couple of different things that can be required. A lot of the payers are requesting your normal range of CPT codes that you would bill for therapy services. Some of them have a limited number of codes. Some of them have specific codes that they want billed. Then on top of the codes, a lot of them are asking for modifiers. Both 95 and GT mean the same thing. Therefore, synchronous, that audio-visual communication, depending on the insurance, will determine which one of those you need. And the GQ modifier is meant for asynchronous communications. Some of the payers are also requesting a place of service O2 to indicate the service was performed via telehealth. Next slide. So let's start by talking about Medicare. Occupational therapy is statutorily excluded from telehealth under Section 1834 of the Social Security Act. So as of right now, occupational therapists cannot perform true telehealth services. Now, this got very confusing with the interim final rule that was released this week that indicated that therapy services would now be covered under telehealth. While the rule did release some of our most commonly billed CPT codes for telehealth purposes, it did not release us from that statutory requirement. So as of right now, occupational therapists still cannot perform true telehealth under Medicare. Medicare did allow a little bit more flexibility, though, under the couple of things that have come out, starting with the 1135 waivers that added the ability to perform e-visits. After the e-visits, in the interim final rule, they also added virtual check-ins and telephone assessments that we'll talk about in a minute. And the CARES Act that just came out and was signed into law at the end of last week did give the Secretary permission to expand telehealth. And we believe that permission includes therapy services, and AOTA as well as APTA and ASHA are actively lobbying to get Medicare to expand these services to include therapists. So fingers crossed, hopefully we can get this resolved soon and be able to perform true telehealth, but as of right now, under Medicare, it is not allowed. That being said, you would have the option of cash pay for Medicare patients. It's not necessarily something we would recommend, but because it can't be performed otherwise, it could be done. I would just certainly recommend an ABN and being sure the patient was entirely on board before you took that approach at this time. Next slide. So let's start by looking at the e-visits. So these e-visit services came out in the fee schedule for 2020, but at that time they were silent on whether or not therapists could perform them. Under the 1135 waivers, Medicare gave therapists permission to use these e-visit services. And there are three services that are the only difference between the three are based on time. Next slide. So what is an e-visit? In that 2020 fee schedule, Medicare described it as a patient-initiated digital communication that requires a clinical decision that otherwise typically would have been provided in an office. It was intended for short-term and performed via a digital platform, which under the waivers they specified to be a patient portal. Next slide. So the billing requirements, when Medicare first introduced these on the 17th, going on 2 weeks ago, the patient was to be established with the practice. The contact must be initiated through a patient portal, but clients could be notified by the office that this is an option. So you can let your patients know that we can offer you this service if you contact us via the portal. The patient must consent. And then once the communication is received through that portal from the patient, all of the time spent during the next 7 days cumulatively reviewing that request, assessing and responding to it would be included in the amount of time that to help you choose the level of e-visit that you would bill. Next slide. As discussed earlier, the patient portal is that secure online website that gives patients convenient 24 access to personal health information. And as I said, under the waivers, Medicare specified that patient-initiated contact should be through a portal. So that's how this visit has to start. Next slide. Here are some examples of the type of services that occupational therapists could perform using an e-visit. If you got the patient portal contact from a caregiver that had questions about ADLs, you could respond with caregiver training. If a patient with lymphedema or wound care concerns had a question about self-management techniques, then you could walk the patient through the wrapping or the wound care that needed to be done. If a patient had a question regarding an adaptive device, then you could advise the patient on how the device was to function properly. If it was a TENS unit, then you could review modality settings, et cetera. Next slide. A couple of other uses. They had questions about fall prevention. You could review balance exercises. If recovering from a CVA, questions about the functional activity program, review home stretching and functional activities. Patient with cognitive dysfunction, again, you can review cognitive worksheets. A patient with ALS had a question about a feeding tube. You could review getting the air out of the tube and functioning, etc. Next slide. So a couple key takeaways about these Medicare e-visits. They are not telehealth. In a sense, they're more case management than they are treatment because you are responding to a patient's question in an asynchronous manner. This is not a video communication. This is a patient sending in a question, you're responding to their question, and getting back to them with what they need. It can only be billed once per 7 days. Again, the time you spend in that 7 days is cumulative up to the max time that can be billed. And if you wanted to see the patient again the following week, the patient would have to initiate that service again. There would have to be another patient portal interaction with the patient asking a question to initiate the next e-visit. Place of service when billed would be usually office or home 11 or 12 where the therapist is located. This is not telehealth, so you would not use place of service 2. It is considered sometimes therapy, so you would need the GO modifier when billing it under a therapy plan of care. Now, I had said when this originally came out, CMS had said this was for established patients only. Under the IRF, CMS is relaxing their enforcement of those established patient requirements, but for this particular type of service, they did indicate the patient must be under a therapy plan of care. So I would use caution before using the visits with a new patient.
Hey, Monica, can I ask you about the on the place of service? What if the therapist is at home?
Then you would use place of service 12 to say that the therapist is at their home. Yes.
Got it.
Okay. This next set of codes that Medicare just gave us access to in that interim final rule are virtual check-in codes. There are 2 codes, and they're actually for 2 different things. G2010 is for recorded video or images submitted by, an established patient. And the G2012 is a brief communication for 5 to 10 minutes. Next slide. Now, a couple of key differences between those virtual check-ins and the e-visits is that these check-ins, they don't specify the media. So it can be a telephone call, it can be an email, it can be through any type of electronic media. The other code would just be a review of if they send you and upload images or a video for you to review. That would be the other code. But these check-ins are meant to be brief. This was meant to be 5 to 10 minutes. The idea originally behind these codes was to see if the patient needed to be seen. So you'd check in with them, how you're doing, do you need to come in to the office type thing, because these were originally physician-only codes. Okay. Again, these are meant for established patients. CMS again is saying they're relaxing that enforcement, but they do have to be patient-initiated. There has to be patient consent, and once again, they're considered sometimes therapy codes. Next slide. The final type of code that we're allowed to bill now under CMS is the telephone assessment and management. Now, Medicare has never allowed for telephone services to be billed, so this is brand new. These codes, there's 3 codes. The only difference between the 3, again, is time, 5 to 10 minutes, 11 to 20, or 21 to 30. Next slide. These codes cannot relate to a visit in the last 7 days. If the patient has been seen in the last 7 days in the office, then you cannot bill a telephone visit.
Does that include e-visit?
That's a gray area. They haven't really said specifically. So I'm not sure if that would be the case. I think they mean more face-to-face, and or if you were doing true telehealth, even if you were doing it as cash pay, I would consider that a visit. And I'm not sure they would apply it to the e-visit at this time, but they were not clear.
Got it, okay.
These, again, have to be patient-initiated. They're supposed to be for established patients, but again, CMS says they are relaxing the enforcement of it, and they are also sometimes therapy. Again, I would just caution, if it's a new patient, there can be some gray areas with, what you're able to even do via telephone assessments, without being able to do true telehealth right now. So I would be sure to be using your clinical judgment if you're using this for anyone but an established patient. Next slide. Okay, so that's where we are with Medicare. Some other insurance carriers have been more generous in what they've allowed at this point in time for telehealth services. So we'll start with TRICARE. TRICARE gave us an update on March 18th, indicating that PT and OT can be billed under telehealth for continuation, but not initiation. So again, this is established patients only for TRICARE. You cannot bill for a new patient. Now, this is where some of the things that Tammy was talking about you have to be careful of. For TRICARE, the therapist must be licensed in the state where the care is provided and received. So you have to be licensed both where the patient is and where the therapist is. TRICARE is still requiring a HIPAA-compliant platform, even though CMS has put out some guidance that that's being relaxed. For some formats, TRICARE says no, it needs to be HIPAA compliant. And then for how the codes are going to be billed, they say if it's synchronous, you're going to use your typical CPT code with the GT modifier and that place of service 02. And if it's asynchronous, you're going to use your CPT code with the GQ modifier. And the link to this resource is there on the slide, which is also in your handout. Next slide. For United Healthcare, the guidance that we have right now is effective March 18th through June 18th. And I do want to mention that these things really are moving targets. The policies are changing daily. There is a possibility, as you know, that COVID-19 could extend these issues beyond June 18th. So it's very important that you're getting the insurance bulletins from all of these carriers so that you can keep up when these policies change. For United Healthcare, they want the place of service 2 and the modifier 95. Next slide. But they've been very particular about what codes they're going to be allowed to be billed via telehealth, and this is the list of occupational therapy codes that United Healthcare will allow. Next slide. Cigna, again, through May 31st, they want the GQ modifier, but they don't want the O2 place of service, and they are even more limited in the codes they're allowing. They're going to allow an evaluation, and then therapeutic exercises is the only intervention code they are allowing. Next slide. Aetna, at this point in time, has not allowed for true telehealth for therapy services. Instead, they are following the Medicare model. They have opened up through June 4th those 3 e-visit codes, and they chose the Medicare e-visit codes, not the CPT codes, so those G codes, and the 3 telephone assessment codes are also currently being allowed. Next slide. Blue Cross Blue Shield, the decisions are varying state by state. So here are some recent telehealth policies that have been announced. Alabama just announced, Minnesota, Nebraska. You can see the links to see what they are allowing. I know I've said it once, I have to say it again. This is so payer specific. You have to go and look at your payer. And if you're not sure if there's a policy that you're wondering if something would be covered, at this point in time, it's worth asking. It's worth making the phone call and finding out if the payer says they will cover it, because there's some things I'm sure they haven't thought about yet as these things keep rolling out. And I have heard providers state that they called and were told, oh yes, we'll cover that. So it's certainly worth going insurance by insurance and trying to find out what they will and won't allow. Next slide. Medicaid also varies state by state. At the time I started this, there were 34 states that had been approved for the 1135 waivers. I know that number has gone up since then. So you want to review the state-specific guidelines for those billing guidelines, because again, every state's Medicaid wants different codes, they want different modifiers, and they're allowing different services. Next slide. Also on the AOTA website, our State Affairs Department has done a great job of tracking these changes, and you'll get the link at the end of the presentation. If you go onto the site, you'll see this even has the date of the last update for these updates, and it tells you the updated telehealth policies and the Medicaid, and if they know of any private insurance policies. So it's a good resource to look and see what changes have happened and what you need to know to be able to bill telehealth for Medicaid. Next slide. And this is an example. If you follow one of the links, this happens to be Alabama. You can go in and see specifically what they are saying regarding telehealth. Next slide. Also be aware that the Department of Education has put out resources regarding telehealth for school-based therapy, and that's a good resource to keep track of what's being required. Next slide. And additionally, the Department of Workers' Compensation is doing the same thing. So within your state, you might want to look and see what the Department of Workers' Compensation is saying. Next slide. Here are some of those resources for you. If you go to the COVID-19 page on the AOTA website, this is how you can get to those state charts. We have telehealth resources, as Tammy mentioned, outside of COVID-19. They have a whole page of resources for occupational therapy. And if you're interested in trying to help get true telehealth services under Medicare, I've also listed our Legislative Action Center, which gives you some ideas of how you can help that fight. Next slide. We're ready for questions.
Excellent. Thank you both very much. I do have I didn't know, we knew we had a lot of slides to go through today, so I didn't want to interrupt while we were going, but I have a couple, if we can, do you mind if I go back through?
Sure, that's fine.
Okay, so the first one, obviously, this, oh, wait, where is it? Where they came out, oh, I thought, this one. Okay, so when they came out on, what was it, Monday, with all of the telehealth codes for PTOT and SLP, everyone was very excited, only to really dig into it and find out that they didn't or weren't able to lift the exclusion because it's under a statute. CMS couldn't take it out. What are the steps that we're having to go through to get that either lifted or overturned, or is it going to be overwritten, and by whom? Is that a presidential order, or what are the mechanisms in place to get that out of the way?
Sure. Well, it is a statute, which means it is a law, and normally that requires legislative action. But in the course of, remember, this interim final rule, they've been working on it for a while. This isn't something that just happened overnight. It's been at least a month of them putting things together. And then on March 27th, the CARES Act was passed, which was practically the day before this interim final rule came out. And in the CARES Act, the Congress gave the Secretary permission to expand telehealth further, and we believe in that section it clearly gives the ability statutorily for the Secretary to expand to therapists. But again, this interim final rule was not a response to the CARES Act. It was something that was there previously, so they had to get that, but they had already been working on out for the provisions that had been already applied. So now what the lobbying is coming in is to go back to them and say, okay, now you have CARES Act permission. Will you use that permission? Because it didn't mandate that they do it. It just gave them the authority if they wanted to. So AOTA, APTA, and ASHA right now are actively lobbying with CMS to say, okay, now that you have the permission, use it. Please allow therapists to perform telehealth. So that's kind of where we are. There was a call with SEMA Burma on,
Okay, so
I believe it happened on Monday.
Okay, I was wondering where that was leading. So it's Secretary Verma's office essentially that has to make the change. That's where this
Right.
is now. Okay, got it.
Yes, and she did mention on it was a stakeholders call on Monday that they were reviewing the CARES Act now, and that there probably would be more regulations to follow, but that's all she said. So we're kind of waiting and seeing what comes out of that.
Okay, and those links that we had that you have on the end, we're going to post those as well on the ACRM page, so they can go directly to it. I encourage everybody to follow the call to action. I did have a question on also the e-visit is pretty straightforward. On the virtual check-in, even though it's really more phone-based, they are allowed to use, if they have access to video visit technology, that they can use that with the patient, right? I mean, because some of the things that you're talking about providing, it may be easier to do if you can see. I mean, it's not excluded, it's just not required. Is that correct?
For the virtual check-in, that is correct. Virtual check-in is it's not limited to the type of technology you can use. What's limiting on the virtual check-in is the point that it's really supposed to only be 5 or 10 minutes. That's all you're getting paid for. It's very, very short.
Okay, and the same with the telephone assessment?
Well, the telephone is supposed to be a telephone call. That's the whole point of a telephone assessment. It's meant to be, telephone should be really the only medium being used for that. And the e-visits, they have to be initiated through patient portal, but that doesn't mean that they can't send you pictures or video or something to look at. And that's the other virtual check-in, is if the patient sends you a video to watching them performing something, an activity, then that's the G2010. That's the interpretation and follow-up with the patient of them sending you a video or images. So you could use it that way.
Because a lot of what we've heard is, they're trying to figure out what services they can provide, and they're going to be providing, and these are at least who we've been speaking with are PM&R department directors trying to figure out what they can do with their staff. So they're trying to maximize the amount of care that they can provide, while at the same time, what can they charge for? How can we keep money coming in so that we can keep people on staff? So if we're looking at the 2010, 2012, if they're providing, but they can't build telemedicine, but they're using video because they want to be able to see the patient to provide the best care. So if they have that available, they would be able to use that. It's just the only thing that they're going to be able to charge at this point until Verma's office overturns the eligible provider provision is a 2010, 2012, but they can provide it they can provide video. It's just not a requirement. Would you say that is a fair interpretation?
Yes, but also keep in mind that these codes, just like the e-visits, are once per 7 days. So it's not going to be a constant, interaction.
Sure, but a weekly, they can have a weekly check-in with the patient.
Right, exactly.
Have that video visit, and we don't know whether or not the virtual check-in and the e-visit are mutually exclusive within that 7 days, right? Because that wasn't, even though I thought that you said that that the e-visit was not considered a visit. Is that
well,
right?
None of these are considered telehealth from that standpoint. So from an actual face-to-face visit via telehealth visit.
There was a word that you used where it was like it's not really a visit.
Case management. It's more case management than intervention or treatment.
Okay. And that's where I was kind of leaning towards, okay, so it would seem like the spirit of an e-visit and your virtual check-in may not have the same 7-day exclusivity from each other that a telehealth visit would have with virtual check-in, and the telehealth would have, because a telehealth visit is a visit, like it's a proper visit, right. It's just done over video, where these other two are sort of visit lights, if you will.
They didn't really say. I mean, these code descriptions specifically talk about an E&M visit or, an actual telehealth or face-to-face visit. They don't mention other types of visits. Typically, though, the phone call, I doubt they'll pay for that within 7 days of anything else, just because of the type of service it is and it being something they normally don't allow.
Okay.
But they have not said. We don't have NCCI edits for these things. It's all too new. And they didn't really say in the rule if these codes were going to be mutually exclusive of one another.
Okay. And then, everything that you've talked about here today, what are the rules for private versus hospital-based therapists? And how are hospital-based therapists dropping these?
That's still a bit of a gray area because the interim final rule called out private practice, even though everything we've seen is under Part B. So you would think that anyone in that outpatient hospital setting or that outpatient skilled nursing facility setting would be able to do this. We do not have that clarification at this time, and we are asking for it. So we will try to get more clarification, and once we have it, it'll be up on our website. But at this point in time, we are not 100% certain about outpatient hospital services.
Okay, great, got it. All right, I'm gonna go to the questions that people were posting. Let me scroll down. So the first one, Jessica, is the AOTA lobbying to add for occupational therapists to bill treatment code for swallowing feeding 92526 with certain pay as Cigna UHC through telehealth at this time. Do you feel that these might be added as these payers telehealth? Do you feel like they may be added to the payers telehealth policies at any time in the near future? So any thoughts on 526?
We are looking at the codes that have been added as telehealth services, and we will, it's depending on, obviously, we're hoping that a lot of this doesn't end up being temporary. We hope that we get to keep some of this after COVID-19, and certainly as those policies evolve, we will absolutely be advocating and trying to ensure that our code sets are properly included. We will look at what's being included now and see if there's any advocacy that can be done. But I put out there, I would still not hesitate to call the payer and ask, because we're finding that in this environment that in some ways that is working.
Okay. So Maria asked, I'm hospital-based outpatient therapy setting. What are we allowed to currently bill? What modifiers are required? I think you were just talking about that, Maria. If she didn't cover that question thoroughly, or if you have a qualifier on that, please post it and we'll ask it. Rose, what's the difference between modifiers 95 and GT? Also, what do you mean when you state considered sometimes therapy?
GT and 95, really, there is no difference. 95 was supposed to replace GT, but as of right now, depending on the insurance, they're choosing which one they want to do. 95 is a CPT modifier, GT is a HCPCS modifier. Not that that really matters much, but they are the same thing, and right now it's been insurance preference. I can't really give you a rhyme or reason as to why the insurances are just choosing it differently. Sometimes therapy means that they recognize that these codes will be billed as part of a therapy plan of care, but may also be billed outside of a therapy plan of care. So whenever these codes are used, generally by an occupational therapist or physical therapist, speech language pathologist, under that plan of care, then they want to see those G modifiers. For occupational therapy, it's GO. So you would add GO to these services if they're performed under a plan of care.
Okay. Next one is from Jenny. She's asking, are AOTAs allowed to provide telehealth under these billing changes? So can AOTAs participate in the e-visit telephone assessments and the things that we're allowed to participate in so far?
So they haven't given a lot of guidelines about OTAs. I'd say it would be done within your scope of practice and under the supervision rules that currently apply. If some of these services exist and would fall under that scope of practice. But I have not seen definitively that yes, they can be used by OTAs or no, they cannot. I can look into that, but that's not something I know exactly off the top of my head.
Okay. Maria asked what sometimes therapy. I think you addressed that. Kathleen, this is this all setting hospital based as well? I may have missed it. I think we've covered that. Can OTs bill for remote patient monitoring?
So as of right now, most of the remote patient monitoring codes fall under the evaluation and management section of the CPT book. And because we cannot bill evaluation and management codes, OTs cannot access those codes. There's been a little bit of it in the interim final rule in the home health setting about those codes kind of being able to be used there, but I haven't seen much more than that at this point in time for the true remote patient monitoring.
Okay. The feedback that we got from one of the guests last week was that they were able to participate in the RPM codes. They just can't drop those codes on the same day that they're dropping other E&M charges. But I don't know if that sounds, if that
again, we can't bill E&M charges, so that's the problem. Is it would be maybe an incident to billing, because therapists cannot bill evaluation and management services.
I think it was incident 2 at this point, until they came out with change under the eligible provider rule. Okay. Right. Where do I find that updated state list you showed at the end? So if you want to mention again where that can be found, we're also going to be posting that on the ACRM page, but please feel free to update on your AOTA resources.
Yeah, so it's on the AOTA resources page of the slide deck. If you go to the AOTA page to our COVID-19 page, and then from the main COVID-19 page, you can go to practitioners, and then the links are there on that practitioner page.
The next question was really more of a statement. Problem is stuff the patient can send via portal is typically limited in size. Most EMRs only allow up to 5 meg. So that wasn't really a question, but just sort of a challenge. Can client have an e-visit with OT and PT within the same week or same 7 days? From Heather.
As long as you're using the correct, GOGP modifier, I don't see where that would be a problem, because it would separate the plans of care that they're under.
Okay. Only qualified HC professionals for RD, social work, ST, PT, OT using, oh, that was from Alan. He's just a statement, he's clarifying something. We're done. So that was all of the questions that we had. I did have one other question on the codes that you posted. Do you have any? We haven't seen any dollar amounts tied to the e-visits or the telephone assessment management. Do you have the dollars behind those codes, or are those?
The e-visit codes, I do have the general dollar amounts posted in an article on that COVID site. That they're not high dollar. I think the highest level code is like $30. So that they're not meant to be high level codes. And the RVUs for the telephone assessment were like 0.25, 0.5, and 0.75. So again, these are not high dollar codes, but they are, will be reimbursed.
Okay. Oh, there was one last one. These are phone codes, right? Alan said they range from 1332 to 3960. All right, everyone, thank you very much, both of you, for, I really appreciate Tammy, Monica, for coming on today. This is a lot of really good information. We will be posting these and the recording of the show to the ABTA's website, along with the links. Tomorrow, we're going to be having on the Southeastern Federal Telehealth Resource Center. There are 12 telehealth resource centers across the United States. They're going to be talking about what services they provide and how they're there to help you. So please tune in. Again, thank you everyone for tuning in today. Please stay safe, and thank you to our guests.
Thanks, John.
All right, have a good afternoon.
Thank you.
All right, bye.
Thank you.